Hi, good afternoon. I'm Dr. Lisa Tartaglia,
Dr. Bone.
and we're here today to discuss a serious illness on kidney disease. We're discussing prognoses of illnesses, and this week's topic is going to be kidney disease.
So the kidneys can be damaged over time just by time itself, but also by hypertension, diabetes. We're not going to go down the path of talking about renal cancer, but we are going to talk about chronic illnesses that result in renal failure and kidney damage. And so those are some of the more common ones. There are certainly some genetic or some anatomic abnormalities that can occur that cause renal damage. And if you do have a polycystic kidney disease, or if you've got some sort of congenital abnormality, you've probably been following with your family physician or your internist and your nephrologist for a long, long time. But now something has happened that you have reached a certain point in the disease. Oftentimes we'll refer to it as that point, and they may begin to speak with you about either dialysis and or transplant. And when those words come up, you know you've reached that point.
Yeah, and it's really important. Hopefully, you've had lots of conversations with your medical team, but if not, when they begin to discuss the critical point of you need dialysis or we need to put you on a transplant list, you need to start looking at having a goals of care discussion, involve a palliative team to have a discussion with you as far as your overall prognosis.
So with dialysis, it used to just be hemodialysis, and then we had the advancements of peritoneal dialysis, which can be done at home. And now we even do hemodialysis at home. It's expensive, it's labor intensive, the family has to be very supportive, and sometimes they have to have enough resources, sometimes not just financial, but they have to be able to understand their disease process well enough that they can participate in those activities. Now, some people have very strong feelings about dialysis, that they, it's like motorcycles. They really, really like it or they really, really hate it. It's not like a Big Mac where everybody's like, yeah, go ahead, I'll have a Big Mac. They don't, it's passionate. There's a lot of passion about whether they want it or whether they don't want it. And some people just fear dialysis because of somebody that they know that had it, but other times people fear the end of life more, and they will accept something that under other circumstances they may not.
Yeah, dialysis is not only cumbersome to the patient, like Dr. Bone said, it's also cumbersome to the family because they have to drive them to and from. And then there's the aftermaths of dialysis. Dialysis can last anywhere from 3 to 6 hours, depending on how well you tolerate it. It's a 3 times a week event, and there's a lot of things that need to be looked at, like how is the patient's functional status prior to dialysis, what's their blood pressure like, what type of diet are they maintaining. All of these things play a role in how dialysis works per se. There are a lot of illnesses that are, it's kind of sad, like autoimmune diseases that affect the kidneys. That affects a younger population. So, of course, patients are going to want to do dialysis because without it, they know
they're not going to survive without it. But it definitely affects their quality of life. I've had patients that had renal impairment and were talking with the nephrologist, and the nephrologist will even tell them, if you're thinking about a vacation, if there's something you want to see or something you want to do, you need to really seriously consider doing that within the next 12 months because your renal function is becoming so impaired that you're likely looking at dialysis within the next year. And once you start dialysis, travel becomes extremely difficult. Even if you're doing peritoneal dialysis, which can be done at night, you have these big jugs of liquid. Basically, they're not water, but jugs of liquid that you have to put into your tummy every night when you go to bed, and then you take them out of your tummy every morning when you get up. And so if you think you're going to leave town for a week, you're going to have all that stuff shipped to where you go, because it's big jugs of these fluids, and they're expensive, and they are precise amounts of electrolytes to help pull off the toxins, because that's basically what your kidneys do. Your kidneys have a couple of hormones that they secrete that tell your bones to make extra blood, but they basically will pull off toxins. So just making urine is not all they do, but the stuff that's in your urine is daily byproducts of medications or vitamins or just stuff waste products
that we take in. Yeah. So it's a very, just like the liver, the kidneys are very essential, and they can get affected by other other chronic illnesses.
Mm-hmm.
So patients that have heart failure, when it goes to kidney failure, their disease is more progressed. And then there's a
hepatorenal syndrome, where one organ system is not working right, and it affects the other organ system. And the heart, the kidneys, the liver, and even the lungs all kind of play a role in how they work together. And so if your kidneys are making urine but they're not pulling the toxins off, you may say, well, I'm not retaining fluid. My kidneys must be working well. But the doctor says on your lab work, your kidneys are putting out fluid, but they're not extracting those toxins. And so it's just like living in your house. You have to take out the trash all the time. You're thinking, where's all this waste coming from? Where's all that trash coming from? And your body is the same way. In the process of living every day, your cells have byproducts, creatinine, the BUN, those things build up in your blood system, even if you're not taking vitamins or medicines that need to have metabolites removed. Your body has things that need to be removed, and that goes out with the urine every day into the toilet. So if they're not making the fluid, it's going to build up, and even if you're making the fluid, those things may build up.
And it's really important when you're looking at, are you a candidate for transplant? Usually transplant is synonymous with dialysis. What's your compliance level as a patient? What is your buy-in to your disease? Because you really have to be very compliant with your medical management, because it's very labor intensive. So if you were kind of a willy-nilly, cardiac patient or diabetic that ended you here, that's okay. No judgment.
No.
I mean, hey, if you just do not want to do dialysis, more power to you, because it's
all about you.
It's all about you and whatever you want, because there's a lot of things that can happen just to get the shunt placed, which is something that is placed in your arm instead of having to get IV access every time you get dialysis. There can be things that happen. You're chronically
It's a large catheter that they use, and sometimes they'll even put a fistula where they connect an artery and a vein, and you get a big blood vessel that they can use for access for the hemodialysis.
Yeah, and that comes with risk. Anytime you have a procedure and you're chronically ill, there's risks that can happen. So sometimes we'll get patients. I've had patients that end up on hospice where they were all ready to do dialysis, but then they had a catastrophic event that occurred, either to make the fistula or in the shunt placement.
And so in the process of deciding if an individual is a candidate for a transplant, they need to do testing on what kind of kidney you're going to need. They'll want to know, are you able to take the medicines that you're going to need to keep your body from recognizing that kidney is not coming from you, so you're going to be able to get the good effect from that kidney, and will you be able to take care of that kidney once you get it? Typically, if you get somebody else's kidney, they're not going to take yours out, but they will place that kidney in your body. They will attach blood vessels so that kidney can have the circulation that it needs, and then they will hook that kidney up to your bladder so that you can evacuate evacuate those toxins when you go to the bathroom, and they'll basically plug that kidney in for you. And if that's successful, many patients can live many, many years without renal problems, but they do follow closely with their nephrologist so that they make sure that they're taking good care of that kidney, and their body is not going to begin to reject it. So they got to make sure that they control their blood pressure. They've got to get lab work done periodically so they make sure that kidney is functioning appropriately.
Absolutely. Now, oftentimes some patients are not candidates for transplant because they have other chronic conditions.
Or they don't want a transplant.
Or they don't want one.
They can't get a kidney in time.
So in looking at that, you have to make sure that you have expressed your goals of care to your family, sit down with a team to help kind of vitalize a plan, to make a plan, to see what your wishes are and how you would like things to be for end of life. Some patients can live a long time with chronic kidney disease and it doesn't go to end stage. And then there's others that come to us really, really at the very end of their disease process, and it is imperative for them to have dialysis, and if they do not, they will die in days.
So I've had patients that I've followed over the years. I had he was military, former military and former law enforcement, and he had hypertensive kidney disease that advanced slowly over many, many years. And when he was in his late 50s, that's when the nephrologist started talking with him about, if you want to make a trip, you're going to need to do it because you're going to wind up on dialysis. And this individual said, I'm not going to do dialysis and I don't want a kidney. I'm not gonna do either one of those things. Well, we watched his renal function change so slowly over so many years that his renal function was finally to the point where it was like 7 times normal, and he was able to tolerate that. When I moved to Florida, I had seen him just a few weeks before I moved down here, and the day I saw him, I got his lab work. I took a picture of it with my phone because his creatinine was 7 times normal. He rode his motorcycle to work that day, or to my office that day. He wasn't working anymore. He rode his motorcycle in to the office that day. Just he had acclimated to that as his new normal. I have to stress that the human body has this tremendous ability to reach a new point of homeostasis. And so if you can get used to something over time, and I used to compare it to, like you got the guy who's going to karate chop the brick. You don't start out with the brick. You start out with the balsa wood, and then you just keep moving up and moving up until finally, you can karate chop the brick. And that's what this guy had done with his kidneys over many years of me being in that area and following this gentleman. He had gotten to where his kidney function had just changed so slightly, incrementally over so many years that he was still very functional. Now, he fatigued. He had trouble with anemia. He still had to take numerous medications for his blood pressure because his blood pressure was always high. But he maintained, for me, it's about my quality of life. It's not about my quantity of life. I want to have a good life, and I want to live it the way I want to live it. So we just supported him the best that we could, and he tolerated that elevated creatinine level for a long, long time because it crept up so slow. I had another farmer that I followed, and his had reached almost, it finally reached 12, so I don't know what that would be, 12, 10 or 12 times normal, because normal is 1 or less, and he was almost 90 years old. And, he had a couple of cows and he had a few chickens and he would take care of them. He finally ended up selling everything because he wanted to move and live with family. And he had no children of his own and was no longer married. He was widowed. He was emphatic, I'm not going on dialysis. I have a farm I have to take care of. And I'm not going to, get a kidney and take it away from some young person. And, we don't judge on what people want. We want to offer it to him if they want it. He said, I want to live out my days with other families. So he moved away to another state to live with some, great nieces and nephews and ended up selling things. And, he chose that was how he wanted to live. And he did very well for himself. He didn't do much and he didn't go far, but he had acclimated to that high level of creatinine and really had a good lifestyle for what he wanted. So sometimes you can tolerate a lot, right? But sometimes you need that kidney or death is looming for you.
Yeah, it's interesting. We all have stories to share about their patients. One of my favorite end-stage renal disease patients that I took care of early on in my career, he came to us directly from a cruise ship. Because I live in Florida, and before I used to live in Southeast Florida, so he came from the Fort Lauderdale terminal right off of a cruise, and he had had diabetes for a long time, high blood pressure, lots of things, and went into the hospital due to an infectious process, found that his kidneys were damaged and they did not return to baseline. So he was offered dialysis, and he was, fully functioning. Like I said, he just came off of this huge family cruise, and he opted for no dialysis at all. He opted for inpatient hospice care because he did qualify because he had symptoms to manage. And what I found so interesting about him is he was the patriarch of this large family. And because he'd just come off of, a huge cruise for the holiday, he pretty much spent his days that he had left calling loved ones on FaceTime on his iPad and basically telling them what he loves about them so they would be okay with him passing. And then every day he would get a little bit weaker and he would say to me, now what will happen at the very end? I said, you're just going to go to sleep and you'll die peacefully because I'll, give you medication to help you. And he was really funny because he always wanted a scotch every day. So I got him a bottle of scotch. We brought it into the inpatient unit. And by golly, he did have one last shot. And then he was very lucky because he had a good healthcare team that we loved on him, our team, and he had lots of closure of his psychosocial, his spiritual pain, his physical pain, his emotional pain, that his passing was just hallmark beautiful. Wow. And the family had all these video clips to share with their next generation because this was going to be a guy they're really going to miss.
So we don't want to tell you don't get a transplant or don't do dialysis. We know you're talking with your nephrologist about that. The side we're presenting is the side that people don't talk about because sometimes people don't want those things and it's not the right choice for them. Certainly if you qualify for a transplant, you certainly want to evaluate, is that something that's going to be right for me? And you want to have that team look into that. If you want to try dialysis, you certainly can. Accepting dialysis doesn't mean that you're always going to have dialysis. I have cared for patients who say, I'm going to accept dialysis because I want to see someone graduate or I want to live for a certain event, but then after that, I'm not going to continue to do that. So it's a very personal decision and it takes a lot of reflection and it takes a lot of consideration and you want to get the input from your other family members about what's going to be right for you, for your choice. But I've taken care of patients who have had a transplant that took and lived many years or had a transplant that didn't work and maybe now they're looking at another transplant. But if you qualify for a transplant, you know that you've reached that point and then you have to think about and reflect on, what is your journey going to be like and where do you want to go from here? What's going to help you live the best quality of life that you possibly can so that it's meaningful for you.
Right. And look at your overall functional status of the patient, the cognitive status, and what's their nutritional status. Because that also plays a role on prognosticating whether or not transplant is a right option or even dialysis. If they're already not eating well, not able to get out of bed, and really already debilitated mentally, what is that dialysis going to do to them?
What's the quality of life for the patient? Because it's really about them. It's not about what we want for them. That's not being selfless. To be selfless is to think about what the patient would want and what's best for them.
Yeah. We hope you found this video to be informative. We're trying to spend time with all of you to discuss topics that people don't want to discuss. So we just want to inform you that you have choices. And thank you so much for joining us today. Wish you well. Have a great day. Bye now.
Bye now.